Hello, I'm Dr. Alan Malik, and welcome to this third webinar in our series on how to set up easy and effective community-wide screening programs. In this third webinar, we're going to get into how to make the business case. In the first webinar, we talked about, how do you make a difference here, which really comes down to how do you make it more effective, which is breadth and connections and engagement and trying to increase that reach and so forth. And so, there's all sorts of different ways to do that. That looks very complex, but once you start getting into how do you simplify that whole thing, which we got into in webinar 2, then the idea is that you flip over to electronic, you turn around and you get your clients to actually do the data entry for you. You automate your process. If you get a fully integrated sort of setup going, like in an EMR setting and so forth, then you've got this thing down to there's like no labor involved with the process. It automatically routes through. And oh, by the way, they can actually bill for those screenings. So they can actually make money at the process. And that's what kind of the stuff that we'll get into here in webinar number 3. So, and then in the last webinar, when we get over there, we'll basically talk about, how do you really do this in the real world? And it really comes down to you download some apps, you start connecting things up, and you just build out your network. And it's really not that much to it. So let's get into webinar 3 here. So the big theme here is, how do you make this whole thing sustainable? And that's the thing that we've seen through the years is, people go in and do grants and they'll pay for everything and get the stuff in there. And then as soon as the grant money runs out, the whole thing kind of falls right on its face. And usually we have to go back in and reconstruct from that point to try to actually build out around this idea of sustainability after the whole thing's crashed, which we probably hit about 50% of the time on, which it's not bad, but you can do a whole lot better with it. So we'll get into that whole process and how do you do that. So, the other things that you get into to help make it sustainable is obviously you want to drive down your costs, the automation, but there's, some other things you can do here if you start buying in bulk in terms of administrations and even in terms of any sort of licensing that you're doing. You can basically volume pricing, which is very useful. And you can actually use that as an incentive for your programs. But the big trick in all this is you need to recruit self-sustaining sites. And then in the process of doing that, you end up distributing your cost. And then, spoiler alert, obviously, on this one is that not only do the medical providers and so forth in the medical community have the best access to that 0 to 3 range, they also get paid for it. So, there's really no cost to them. It's actually a profit center for them if they set it up right. And then we get into issues about, okay, if you're not going to get it through self-sustaining sites, then, are you going to use a public portal to get there? Are you going to use personal apps? Are you going to, and how are you going to support those? Because you're going to have to do follow-up. And so do you hook those over to, say, a public health program where you've already got budgeted support in there or not? And bottom line in all this is that, you want to have your data sharing in place so that you can actually promote performance. Basically monitoring your program and promoting and managing and marketing and so forth. These are all part of making everything sustainable. So you got to take all that into account when you think about a sustainable program. But the reality is you can get away for a relatively small amount of cost as much as you can hook it up to processes that are already in place or to funding that's already in place that are already budgeted. Then, more power to you and the better you're going to go. But the whole thing that you want to do here is when you're laying out your program, you really want to think about it from a sustainability perspective. And because that's the only way it's going to last. Let's get back to our systemic context sort of idea. And the reason why we want to look at this point is that we really want to get down and understand this idea that in terms of getting access to that child and getting the right information out and doing the right amount of detection, getting the referrals in place, is that you really need to think about your primary point of entry and point of contact is actually through your providers, through your medical providers during those well-child checks, because they're going to see them for the immunizations is really what it comes down to. And so anything that you can do to help support that process, basically I'll give them a better and easier ability to refer and connect to resources, anything that you can do to help them integrate into their EMRs, because that's ultimately where all those guys go. They do not want paper, do not attempt to get their PHI outside their system and so forth. A couple of the things to think about from that provider perspective is that you also need to understand, especially if you're coming from the early childhood arena, is that providers believe that they are actually responsible for the health and development of that child. And ultimately, when you're working with them, you need to understand that you got to be careful that you don't look like you're actually interfering with their ability to do that. So you don't want to be driving process on them that doesn't really make sense to them. You don't want to be creating more work for them. You don't want to do things that are counter to what they think is right clinically and so forth. And, to a large extent, what you want to be doing is providing resources and showing them how to better handle that essentially when they become a gatekeeper. How do they, what do they do about those sorts of things, and what kind of resources are available to do that? And the other thing to think about here is that traditionally, providers do not mix with the early childhood arena and so forth. And so they're kind of off doing their own thing over there. And so when you want to try to work with them and understand that you don't want to become interfering with their process, but you also got to understand that they need education. They need to understand what's available, and their world is moving forward as they go through things as well. And so, what ends up happening a lot of times is when you try to put this program together, you probably need to go over to that medical society in that community and try to find some early adapters. I mean, when you talk to pediatricians who have actually engaged in these programs and so forth, they say that's probably the best way to contact them and get into there. And just understand that there's a certain portion of that of that group that they're not going to want to engage with you, and that's okay. But you go find those early adapters in that group. You get some of the younger physicians and so forth who really want to really want to get out into technology, get out into sharing, get into the biopsychosocial side of things, expand that whole process out. Those providers are pretty good listeners, and they're actually, just like everybody else, they want the best for the child. They're all you're all on the same team. You just got to realize that and get yourselves working together. So anyway, we'll get off the systemic context, but you'll think about this as we start talking about how do you fund things, how do you engage people and so forth, and get them involved as far as making your business case. First thing you want to do on the business side, obviously, is reduce cost. So first thing, on just a pure material cost basis, you can sit back and make an argument for going electronic. If you're already doing it on paper, you're spending money creating paper, you're spending money storing paper, you're spending money printing, all that kind of stuff. Where if you're doing it electronically, basically you have none of those costs. You do have potentially server costs or data storage costs and so forth, but they're much reduced relative to even the cost of the paper. Then you got to start thinking about things like, all right, what are my error rates associated with doing paper? So those hand calculations and so forth, what kind of cost are you creating there? And then you move over to, if you start automating your process, you start doing all these things automatically, you can start reducing that staff time. And so like we talked about, where you're fully integrated with an EMR, that EMR at the time it's scheduled can automatically generate that notification to go out at the right time and do reminders, go get that screening done, and actually have it show up back in the EMR, and staff didn't even have to get involved with it. So, all that gets locked down when you start doing that seamless integration. So you just drive down costs for everybody. And then the third area where you can drive down costs, which we mentioned in the opening, was about the idea of getting some volume pricing going. And so when you start working your whole program together and pulling everything together as a group, then you can basically set up single contracts, get those volume pricings going down, and then you can provide that out as an incentive to your members of your group and so forth. Along with reducing costs, which automation does for you and so forth, and going electronic does for you, the biggest thing that you want to do from a program perspective is you want to distribute that cost. And we've been talking about to this a bit, but it's basically you want to have sites funding their screening and their follow-up. And the primary and the best one for doing that is actually inside a medical clinic. But, you can find the early education centers and so forth, they're willing to put that out of their budget as well. And so, because there really aren't that many kids that they have to screen, so there really isn't that much cost associated with the whole process. If you can get that per child cost down to, under $1, with everything included, if you only have 25 kids in your program, it's not a big deal to cover that cost. And the big thing, though, is you just drive it out and distribute it, and then you don't have to worry about carrying it. Those people get involved. It becomes part of their program, becomes part of their marketing. They're using it all the time. The big one here, though, is you got to get to those medical clinics if you really want to get your reach out there. The medical clinics are driven by those AAP guidelines we talked about back in webinar 1. Those AAP guidelines do mean something to that medical world. And just from a professional perspective, they need to be following those sorts of things. But the big thing to them is that, they have access during that well child check. And so they have the best access, especially in the 0 to 3. When you start getting up to 3 to 5 and so forth, then maybe that works a little bit better in the early learning centers and so forth. Or, by the time you get up into, preschool and so forth, now you're getting into programs or even into kindergarten and so forth. People, a lot of times that's where the first time they see is when they hit the educational system. And kind of at that point, you're a little late to the party on in terms of taking care of things. You really want this as early as possible. Early detection is the key to all this. The other advantage inside of a medical clinic is that they can get reimbursed. Now, the reimbursement moves all over the place because everybody's, doing their cost shifting and all the other fun stuff that goes on inside the medical world. But there is a CPT code out there, 96110. And I even know the doc that got that put in place. He was working with a program. Actually, it was actually part of the ABCD, the original ABCD up in Minnesota. And he just went to Blue Cross Blue Shield and said, give me a billing code. He was actually a child psychologist. He said, give me a billing code. And they gave him 96110, and it stuck. And it's used on a national level at this point. It's innovative people getting out there and doing things. Next thing that you need to think about is that seamless integration with that EMR. Docs do not want, they hardly have any time with a child. So you need to summarize everything into their EMR. So they can turn around and say, we're going to put that on staff to try to get that information in and get it into the EMR. But now you're biting into their staff time. But if you can seamlessly integrate this entire process, this concept of fully integrated with your EMR, then that solves that problem for them. And you just can't get away from that. And the caveat to that whole thing is also that don't try to store their PHI outside their system. Their PHI has to stay with their EMR and inside their system. And then the other thing we're starting to get into that people are starting to realize, even down in pediatric clinics, that this whole concept of a behavioral health therapist, that integrated behavioral health component of this, start getting that social emotional side of thing where normally you would have referred them off to a child psychologist. You can actually handle a lot of that with behavioral health therapists. There's a great deal of advantage to that brief intervention sort of thing, because those in the moment it's a very teachable moment and so forth. And so they are very successful from a behavioral health therapist perspective. We even have a clinic where it basically the program was put together that they went out and had the community mental health center basically hired the behavioral health therapist and put them in, basically paid for them inside of the pediatric clinic. And then the concept was they had 3 years to get themselves to being, essentially self-sustaining, but, in basically being a profit center for the mental health center. And basically the therapist they put in there was good within a year and a half. And then the pediatric clinic, they are actually making money off the screening. So it's a profit center for them to screen. It's a great resource and a great service to have immediately available in terms of the behavioral health program. And then the behavioral health program is actually making money. So it's a win for everybody. And it's a great way to get screening pushed into pediatric clinics and so forth. So anyway, different ideas on how to approach that medical community. But the big thing is you have to really understand where they're coming from, that systemic view of what they're trying to do. And then you're going to have to go out and engage them. And history is not in favor of those types of conversations and so forth. I often run into the early childhood group that basically says, we can't work with doctors, or they've had way too many bad experiences with doctors. I would say, rethink your process, maybe give it a try, go try to find some early adopters like we talked about. But we definitely have programs that are doing this sort of thing. And once you get integrated, it's not even a question anymore. up in Grand County, which we'll talk about here in a little bit, everybody was really reticent of trying to work with one another early on in the program. But once you got it going, everybody was like all over it. I mean, and you don't even think about it anymore. I mean, everybody's talking to one another and everybody's working together. It's actually a great thing. You also need to, obviously your services, your child find, your EI, they're all trying to, basically they're trying to find clients and so forth. They're trying to bring people in for evaluations. So they're always looking for people coming in. So you don't have to worry about paying for them. You just need to figure out how to hook up to them and so forth. And then, you start thinking about things like this program membership. I mean, it ends up, it's almost like a marketing cost for a lot of these programs to basically do screening. And so to a large extent, even if they can't get reimbursed, they're going to do it from the standpoint of just process within their organization, meeting their AAP guidelines. In many cases, they claim that they can't get reimbursed for it, but they're already getting paid on maybe a capitated basis for handling those children and so forth. But you got to convince them and get them to understand that this is better process, it's lowering cost, and it's stuff that they should be doing anyway. And so basically you're giving them a better way to get it done. And it should just be a cost of doing business. A lot of arguments, big topic area, but if you can take all your screening sites and just distribute out to them and have them all doing their work totally independent of you and your funding, maybe you help them with some startup costs and so forth, but you get them out self-sustaining, then your engine is already running. And then after that, all you're really doing is looking at your aggregate data and helping feedback information, helping training and so forth. But your engine is running and everybody's making it work from their own perspective. Kind of pulling back from that now, you kind of think about this public portal option, because most programs are going towards this idea of, let's just put in a centralized and we're going to get everybody going there. So I think we've kind of really bitten pretty hard into why you don't want to try to take a medical organization and push them into, say, a central portal like an ASQ Online. But you also need to think about, obviously you are thinking about, by the way, if you bring somebody into a public portal, then you have to have maybe a call center to follow up on those people that flag and so forth and doing that follow-up. And so in large statewide programs and so forth, major programs along those lines, then I guess it kind of makes sense that you're going to have to do those sorts of things. But the reality is if you can push that out and get the screening sites doing it, and then let the screening sites set up their own public access. Basically, when you get it done before a visit, or even if you just get it done through public health on a county level and so forth, where they don't really even come into the agency, but you're just hitting them at certain times, you can get all that done remotely, and it's all done branded to that particular organization. It's done through their own programs and so forth. And then at that point, you kind of get into this distinction of the integrated access versus the open access. And so I would try to talk about, like ASQ Online is open access. Just anybody can go hit it. They basically have to connect themselves to the appropriate sites for somebody to get in and follow up and manage them and so forth. What you want to do instead is you want to have that connection already made to that profile, and then you turn around and you send them that notification to get them to go to your portal, and then have them go in and do their work. Or you just send that text directly to them and just do it right on their phone and don't even bother going through the portal for them. Or you catch them in the office and so forth. The program we'll talk about with Grand County and so forth, you'll see that they don't really even use a public portal. I mean, there's effectively when you use a text link or an email link where you go direct, that's essentially, you're using a portal, but it doesn't look anything like a public portal at that point. And it all gets billed back and is actually operated by this individual screening site. So this, a public presence for your organization, you obviously want to have a website along those lines. And then if somebody wants to hook in, then maybe you get them so that they can route them over to the appropriate organization. And then some of the, basically you can set up organizations so that they can actually log people into their organization on a managed basis from their own, but you're basically working them at a local basis, and you don't really want to keep that screening activity at a centralized basis. It just becomes too difficult to manage. So just a lot of things to think about. Understanding that, public portals, ASQ Online, I mean, they make a lot of sense in certain situations. But if you've gone through this process of networking, distributing your workload, distributing your costs, you're going to find that, the public portal concept, you just want to decentralize. You want to push everything out, and takes away all your cost. So then we get into all the data sharing sort of thing. And so we're really talking about, you want to have that MCO in place, your memorandum of MOU rather, memorandum of understanding in place, and then you want to push out your quarterly reporting. And as we talked about in webinar 1, to help control your process, then you're really looking at screening rates, you're looking at the flag rates associated with that, and then you're looking at the flag disposition rates, what's happening with that information. Pushing that information out and making it transparent to the entire community gets everybody's attention, gets everybody online. Then when you go out and you start doing your technical assistance and so forth to the providers and the ECCs, boom, everybody's like locked in immediately. Look at my numbers. Here's what's going on. Let's talk about how that works for you and see what we can do to try to improve those numbers is really what it comes down to. Then you need to think about marketing it back out to not just, doing technical assistance out to the different programs, to the different providers and so forth. Think about marketing your program. You can actually, like up in Grand County, they were putting newspaper articles in. They got to the point where they actually had a mom show up at the office who had heard about the program through articles and so forth, through the normal public relations sort of activities, and knew that they had all given away iPads up there to all the different screening sites. And so, they didn't present her with the iPad right away when she came in the office. They had her doing paperwork and stuff like that. And finally, she just kind of blurts out and says, "So where's my iPad?" And it was like, total parent engagement, but it was all done through public relations and so forth. So, that side of it. And then as well, you kind of need to get out there and use your data to go back to your funders to show them that, your performance is going on and so forth, if you've got any funders associated with the process. And then your data is available for more grant writing, and even you can do your grant reporting through your electronic systems as well. So data sharing is a big component, and when it just comes for free, if you've got all your screening sites doing everything electronically, it's just a matter of a few more clicks and you're into the data that you need. This whole concept of build a sustainable program. So it's kind of this idea of you kind of create this and market your program, so you got to go through this design process where you're going to work on your breadth and your reach and your connections and your engagement. And then you try to figure out how you're going to distribute your workload and distribute your cost. And just think about those systemic sort of things about who's doing what and what makes the most sense to what people, and who's going to get involved with what. And then you start going out and recruiting. You market your design and everything out to the community, and you start recruiting screening sites. You recruit your evaluation and services sites, and then you can start hooking these people together. And once you get people going, and then all you have to really do at that point is just get them online, support. You don't even in many cases have to do the training, but most people like to get into the technical assistance. A lot of locations just go with online training anymore. You just kind of hit into essentially YouTube, basically a YouTube channel with training information on it, and drop everything in and just get people going through that route. And then, at the end of the day, to what extent you have to go through to keep with your technical assistance, or to what, if you can get these organizations simplified enough that they don't really have to do that much training when new people come on. All you really then have to do is just kind of monitor your data and just get the organization itself to move up into better practices and better processing and so forth. Once you get that kind of worked its way through, eventually you don't have to go in there that often anymore. They can basically carry themselves. And so you kind of fall back from that supporting the implementation and training over to just your monitoring performance. And you're providing feedback. It gives you a great reason to talk to all these people. You can pull everybody together. You can start planning where you want to go with stuff. It puts you, basically what you're trying to do now, but you actually have real data to do it. And it allows you to actually implement your programs, make them sustainable. So let's talk a little bit more about that Meeting Milestones initiative. That's kind of like the case study for this particular webinar. And so we've talked a lot around a lot of these people, around a lot of these pieces of information and so forth. But the big thing that happened up there is they just went in and they basically, it turned out it was part of a larger called Grand County 2020, where they went in and the county itself got together and kind of said, well, what are different initiatives we'd like to do that we think we want to have in place by 2020? And they were doing this back in the late 2009, 2008 time frame and so forth. And so one of the things they chopped off is they said that they wanted to do this meeting milestone idea, which is really kind of the AAP guidelines, and they had input from, ABCD Colorado. One of the people on the program up there were around that and so forth. We got involved. We got on the team as well, and we were on the daily not daily, but the weekly sort of meetings where we checked in and went through the implementation process. We did all of our development around that program up there, as far as all of our apps and all this connection and social media sort of concepts were all done around those programs. But at the end of the day, what they ended up with is they ended up with this community roadmap, which is, that's their big organizing point. And they found it incredibly effective for pulling the different groups together. Everybody was giving their input. You got your buy-in off that sort of situation. You knew what to do. You basically knew when to screen. You knew where to go and all that kind of stuff. And they ended up recruiting every single screening site in the entire county into the program. So they had all the early learning centers, all the child care centers, all the medical clinics, the schools, the public health. I mean, even going out to, I think they ended up doing some health fairs in there as well. But anyway, the whole idea being, though, that, everybody was doing screening electronically, and all that information got shared that way. Then they were, basically we're even still working on some of the hook-ins into early intervention and child find and so forth. They have one organization up there that does that sort of thing, but basically then you can do your flags and referrals over to refer off for your evaluations or refer to for services, and you can actually track that information. Still combing through some of the pieces associated with that. And then the big thing that they got into right away was this quarterly reporting idea. And it was just, basically it was an evening at one of the local community centers and so forth, and had all the people that were involved in the screening come together and put out a little food, and everybody talk about how the screening is working in their programs. We'll go through the numbers, and it just got everybody into the process. And eventually it was like, we never expected to get up to 90% reach, and suddenly we're there, and it was just like, wow. And they don't even have a public portal involved in the process. It's actually pretty cool, pretty good. It's actually a great program up there. You should learn more about it. That kind of gives you the background pieces here. I mean, we're basically getting this idea of, if you want to make a difference out there, you basically want to expand what you're already doing. You just want to make it better. You want to get better reach. You want to get better connection, better breadth, more engagement, and so forth. And so to do that, you're going to have to kind of switch your ways a little bit, go electronic with this thing, automate your processes. It's about the only way you can effectively do it. And then along with all that automation, you want to distribute all your workload, and that takes the basically all the cost off of your programs. And then now it just comes down to managing data and basically coordinating activities and so forth. And it's a great way to push forward. So anyway, I think hopefully we got those three pieces in, kind of making a lot of sense. So what we'd like to do on this fourth webinar that we're coming up on is we'd like to get into the real nuts and bolts of how you put all this together and what it's really going to look like for you. But the big thing to understand here is that to make these programs work, all you really have to do is do some downloads on some apps and hook up some connections, and you build out that network, and you're pretty much where you need to be. It's not that difficult a thing, and then you just get into being the data person involved with the process. So anyway, look look below from the links for webinar 4, and also I think down there you can go back and see any of the previous ones, and then leave us a comment if you would, and hopefully we'll see you back here in webinar number 4. Thank you for your time.